I'm going to talk today on essential biomarkers in lung cancer, and this is going to be a clinician's perspective. I'm a hardcore clinician, and at best, been in the field for 30 years. Not very, never been taught NGS. Learned it on my own over a period of time, and learned it from people like Kumar and Anuradha and Ulas. So I'm going to give you a clinician's perspective. So many thanks to Anuradha for this wonderful meeting. I really enjoyed this workshop and looking forward to tomorrow also for this fifth lung cancer year-end review. Anuradha and me, we were together at the Tata Hospital when I was there. She used to work in the lab there. She hadn't done her PhD at that time. So, we kind of learned oncology. She learned lab oncology. I learned clinical oncology together. And since then, she's been such a huge help to me. Like we've worked quite a lot on CML, and I'm really impressed with the fantastic work she's doing. And we look forward to support from her and from her group and Tata Hospital with setting up our molecular oncology department and doing some projects with them. So I think you've seen this slide. When I was, learning oncology, lung cancer was pretty simple. Like it was a histology-based subtyping, and you could just start treatment with knowing whether the patient has small cell or non-small cell lung cancer. But now things are a lot more complicated. You have all these mutations, and you have these rare mutations. And I'm sure this piece of the pie, which at the moment comprises about 1/4 to 1/3 of patients, in which no driver mutation is detected, this is going to become narrower and narrower as our testing for genetic mutations gets deeper and more refined. If you talk about EGFR mutations, it is much more common in our country and in other Asian countries. Comprises in most of our Indian settings of about 1/3 of our patients. More common in never smokers, adenocarcinomas, females, Indians, Asians. Predominantly located in these four exons 18, 19, 20, 21. And it is extremely important because these can be sensitizing mutations. They can confer primary resistance and de novo and acquired resistance. So as you can see here, the landscape, most of the mutations are either in exon 19 or in exon 21. There are other rare mutations which I think are important also in patients who do not have these mutations. And I really like the idea which Ullas propagated that, a reflex testing. You rule out these common guys, and if they are not there, then you move on to and test for the rest of the mutations, and you save the patient a lot of time and money. So this is just about the same. These are the rare mutations, comprise about 10%, and for this, we really need more complex and more expensive testing. Now, why do we do all this? Because we have targets for so many mutations. KRAS mutation, which is the commonest, you now have FDA-approved agents for KRAS mutations, particularly the G12C mutations. Of course, we have first generation, second generation, third generation drugs for the EGFR mutation, similarly for ALK mutations. And also for all the rare mutations or most of the rare mutations, we have very effective targeted drugs. And that is the reason why we really have to look for these mutations, whether the common ones or the uncommon ones. So I think this again, we've already talked about this. Now, like once you have a patient with lung cancer, you have a biopsy, you of course want to know whether it is squamous or non-squamous. You can do immunohistochemistry for that in addition to just histopathology. And you must look for at least these 4 or 5 gene mutations: EGFR, ALK, ROS, BRAF, NTRK, RET, MET exon 14. And you have targets for all these. A broad-based NGS testing is the easiest way to do and find out all these at the first go, but there are certain downsides to that, which we will talk about subsequently. All patients with non-small cell lung cancer, particularly patients who can afford the checkpoint inhibitors, we must look for the PD-L1 expression. Usual turnaround time, as we've already discussed earlier, is about 10 days to 2 weeks. Clinicians would like this to be as short as possible, and as was mentioned, we would like this report yesterday. The turnaround time for PD-L1 is much shorter than when you get the report for NGS, and then you are in a bit of a dilemma. If you have one of the targeted genes mutated, then the checkpoint inhibitors don't work, and you by and large have to wait for the NGS or the PCR and rule out these mutations before you think of a checkpoint inhibitor in your patient. So these are some advantages and limitations of single gene testing and multi-gene testing. The advantages of PCR and looking at a known single gene mutation, that it is routine in practice. There is a potential for local implementation, rapid turnaround. You can get a report in less than a week, sometimes in just 3 days time. Higher sensitivity with the PCR platforms are there, and thanks to epidemics of H1N1 and epidemics of the COVID now, you have PCR labs in quite a lot of institutions in the country. Even government labs are there who have the PCR facility, and they can be very easily sensitized to look at cancer genetic mutations also. Limitations are that they consume a lot of tissue, and we know that tissue is an issue. And if you exhaust tissue in the first 2 or 3 tests, then you may need to do a repeat biopsy or look at liquid biopsies. On the NGS, on the other hand, the tumor requirement is much less. You can do multiple biomarkers at the same sitting, and you don't need to know the biomarker. You can look at and find and detect new biomarkers also. But generally, the turnaround time is longer and it is a little more costly. And the availability is much, much less as compared to the PCR. And again, singleplex and multiplex testing, Dr. Deepak Mishra has already highlighted this, some of the pros and cons of these. And these are the various targets which we look for, and this is the testing methodology. And you can see that in the testing methodology, the one thing which is common is that NGS can detect all these mutations or rearrangements or amplifications. So theoretically, NGS does appear to be the good way to go, the easy way to go, the comprehensive way to go. And again, you don't need to know which mutation to look for if you do the NGS, and you can find new mutations also, which may or may not be important or relevant, but you can find them, which is a good way to go, particularly if you're doing clinical trials. And if you are doing the PCR, as already mentioned by Dr. Mishra, you could do real-time PCR, or you could do RT-PCR, or you could do digital droplet PCR. Advantages being low input as compared to the NGS, fast turnaround time, and disadvantages that you need to know a priori the mutation which you are looking for. And if you look at NGS, you can find rearrangements, copy numbers, variants. All these can be detected at a single test. And there are several commercial laboratories which are now offering this. Then again, knowing and finding out which is the reliable laboratory is a bit of a challenge for clinicians. And the advantages and disadvantages of the NGS have been pointed out in the previous presentations. We also have liquid biopsies. I think all of you are aware of the concept of liquid biopsies. It can help in prognosis, risk stratification, identifying therapeutic targets, monitoring response to treatment by doing serial testing, detect resistant mechanisms, and avoid repeated tissue biopsies and puncture of the lungs and its consequent complications. So it is minimally invasive. It provides a quick turnaround time, and it may be the test which overcomes the problem of tumor heterogeneity. It has some advantages which you've already talked about. It has some disadvantages also, like low sensitivity, about 70 to 80%, high false positive rates, especially in small tumors in early stage, in which the shedding in the plasma of the tumor material is limited, and there's some other problems also with liquid biopsies. And world over, there is not only in our country because of cost constraints. World over, there is a barrier to universal biomarker testing, and some of these have been identified. Some of these barriers have been identified, and these include communications, tissue acquisition, and tissue is the issue. Major problems, at least in our country, are payment and reimbursement issues and the turnaround time. Like this is my take, and I presume that this is the take of most clinicians. We feel that all patients should be tested for at least EGFR, ALK, cross mutations, and the PDL1 expression, because we have generics available for targeting these mutations, which can be in the reach of most patients. And then NGS, I feel, my take is that all affording reimbursing patients, you should ask for the NGS. Of course, all patients on clinical trials, because additional information is very important, we should ask for NGS. And most patients at large academic centers, say like Dr. Ullas Batra's center, or Dr. Deepak Mishra's center, or Dr. Anuradha, Dr. Kumar Prabhash's center, you guys must do the NGS so that India-specific mutations can be detected and Indian data can be generated. And I'm very happy to say that this is already happening, and at least at RGCI and TMH, some really great work is being done and is being published. Now, not doing the NGS, I think it's still, the majority of the patients fall in this group. And the main reason for not asking for an NGS is the non-affording or the borderline affording
Sir,
patients.
sorry to interrupt,
This is
sir.
my last slide. I'm winding up. For patients who have out-of-pocket payments, patients who are on government support programs like the Chiranjeevi Yojana, which we have in Rajasthan, supported by the government of Rajasthan, in which there is no support for expensive molecules or anti-PDL1. So you would just like to know EGFR and ALK in those patients, and not want to know other mutations, because there's no way you can arrange those or the patient can afford all those. So with that, I'd like to conclude. Some of what I've said is a little bit of repetition, and this again is a repetition. Make SMS your habit. Follow soap, mask, and social distancing for your safety, your family's safety, and for the community's safety. Thank you very much.